Hello, everyone, and welcome to your annual Legacy Circle Luncheon. I'm Joan Chaney, Director of Planned Giving for the Foundation for Barnes-Jewish Hospital. We are so grateful you could join us today. To those of you who are joining us virtually, welcome, and thank you for being a part of today's program. Whether you're here in person or with us online, you are among friends who share a common bond of visionary generosity. We are honored to celebrate you and your incredible commitment as members of the Legacy Circle. Because of your estate gift, charitable gift annuity, beneficiary designation, or endowed fund gift, the future of healthcare is brighter. Thank you for taking the time to plan such a thoughtful way to make a lasting difference for so many. Your generous hearts are ensuring support for life-changing research, exceptional patient care, and innovative nursing education. You are creating what will be part of your legacy for years to come. So today, we honor you and offer you our heartfelt gratitude. We have a fascinating presentation for you today with Dr. Tsuyoshi Kaneko, who will talk about the incredible advances in heart and vascular care at Barnes-Jewish Hospital. But first, we'll pause for lunch. The program will resume shortly with Dr. John Lynch. Thank you.
Well, good morning again. Nice to see you all, and it was nice to visit with some of our Legacy Circle members before we got started for lunch, and their guests. So, my name is John Lynch. I'm the president of the foundation and the president of Barnes-Jewish Hospital, and I have the extreme pleasure of being able to introduce our speaker in a minute. But first, I want to acknowledge a couple of folks. Thank you, Joan, for kicking us off. Thanks to our foundation leadership for getting us together today. And so for everybody in the foundation, a big round of applause. Thank you so much for our team members. Also, thanks to our catering staff for lunch today. Really, really fantastic lunch. Thank you all, team. Thank you for your service. And to our videographers and such. So, I would like to just open up with a couple of thoughts before we get into introducing our speaker and the topic of today, which really is focused on cardiovascular medicine and the investments we make together in really one of our premier programs. What you all do as legacy donors and as part of the Legacy Circle really allows us to develop world-class programs. It allows us to attract world-class talent. You're going to get to meet one of those folks in a minute. And allows us to serve our community in a way that most other healthcare organizations can't do. We can take the long view on serious medical and surgical conditions, and your planning, your philanthropy, your approach to supporting us allows us to make substantial investments in our programs, in our facilities, and therefore better serve our community. And again, if it wasn't for all of you, we would not be able to do what we can do on the campus of Barnes-Jewish Hospital, across BJC, with the foundation, with our community health improvements, and most importantly, with our partners at Washington University, building really world-class programs. So, maybe some of you have noticed just across the park that there's a fairly large building going up right on Kings Highway. And one of our guests asked me, what's going into that building? And so let me tell you what's going into that building. One, it's about 10 years of planning to complete really a very large phase of our campus renewal program, which started with the Siteman Cancer Buildings and our OB programs, and the regeneration, the rethinking of the campus on the north end. So where the Legacy Jewish Hospital existed, and those programs up there were then remade into that building. And now we're completing, in about 18 months, the south end of the entire campus renewal program. And so in the new building, which is on the location of the old Queenie Tower. So many of us spent numbers of hours there. I spent literally thousands of hours in the old Queenie Tower taking care of patients and running those steps, and have some very fond memories, particularly of that beautiful restaurant up at the top that many of you all experienced over the years. And now we've replaced that building with really what is a state-of-the-art cardiovascular building. And the first part of the building will actually have a lot of key support structures like we did on the North Campus. There'll be wonderful meeting areas, really nice gathering places for our team members and for our visitors and patients. So we'll have cafeteria and outdoor space. We'll have radiology services moving in. I know Angeline is here and she's busily planning all those moves for radiology. We'll have perioperative services, recovery areas in there. But most importantly, we'll have beautiful new all-private rooms and 2 new very large state-of-the-art ICUs in the top part of that building, all dedicated to cardiovascular medicine. So many of Dr. Kaneko's patients will be enjoying those facilities in just a few short months. The building itself is really interesting. We actually got a grant from the federal government to sort of up-armor and future-proof the building to the best of our ability, so that if we ever have to face another pandemic, and it's actually likely that we will, every one of those rooms can actually be turned into an ICU. So we re-engineered the space, the HVAC systems, the air conditioning, the way we flow and filter air, so that essentially every room can become an ICU if necessary. So a lot of thought went into the building, our best thinking about how to support both our patients and their experience, but also how to provide safe care and how to support our team members that do such an amazing job taking care of our patients. So again, without the help of our very generous community, and you all represent them for sure, we would not be able to make these types of investments in our programs and in our community. And so once again, thank you all. So at this time, it's my extreme pleasure to introduce my colleague, Dr. Tsuyoshi Kaneko, who is the Shoenberg Chair of Cardiovascular Surgery. Dr. Kaneko joined us about 2 years ago now from Boston, where he led a very, very innovative program in minimally invasive surgery. I know he's got a number of stories to tell us and to update us on that program, but let's have a round of applause for Dr. Kaneko. Thank you.
Dr. Lynch, thank you very much for the kind introduction, and I am so honored and privileged to be in the front of this Legacy Circle celebration lunch. I'm very glad that I did not have to have a glass of wine. I typically don't do well after drinking, so hopefully today's presentation will be good. So the topic that I was given was future of cardiac care, and I told everyone that was just too big. I'm just a cardiac surgeon, just a heart surgeon. So I asked whether I can talk about the past and the future of cardiac surgery, the heart surgery, and I would like to share some of the stories. And those of you who were at my chair installation just talk, I love history. That's my passion. So I would love to start from a history slide talking about Dr. Berloff. He's one of the most famous surgeons that existed in the past. He practiced in Vienna. At the time, Vienna was sort of the center of medicine at the time, and he was an abdominal surgeon. So those of you who has done abdominal surgery, he's known for this Berloff surgery, which is basically a surgery for an ulcer, gastric ulcer. So he would cut it and then connect it with an intestine so that those stomach that perforated from a gastric ulcer would survive. So this really, really famous Dr. Berloff, he said that no man should operate on human heart. So that's a statement that he made. There's a second statement that he said. He said, no man dare to operate on the human heart. So that was the statement at the time. This was in the 1800s, where operating in the heart was thought to be too lethal. We should not be doing any of this. Again, there's some question about this statement. So some of you who know history, Marie Antoinette made this statement. If people have no bread, let them eat cake. So this is a very famous phrase, but there is no record in history that she has made this statement. So this is one of the examples. The second example is, I don't know who loves Roman Empire history. Honorius, he's the empire at the later phase of the Roman Empire. And at the time, the capital of Rome was not in Rome. It was in Ravenna, which was outside of Rome because of the protection purpose. But he had this rooster, and the rooster's name was Rome. And there was an attack from the Germans at the time, and the eunuch told him that Rome has perished. And he said, no, but there's just taking food on my hand. He was just talking about his rooster. And I fear that it was my beloved rooster, not the city. So again, this is a famous story, but this also has no record in history. And there's been some claims that, that Dr. Berath never made that statement. So there was an article in our journal stating that he has never said it because it gets quoted so many times that we should not be using his quotes of the heart should not be operated in the future. Nonetheless, turn the clock a little forward in 1923. This was at my previous institution, Brigham Women's Hospital, formerly known as Peter Bent Brigham. The former chief of surgery was Dr. Elliot Cutler, who was a very prominent surgeon at the time. And he performed the first valve surgery. This was back in 1923. So if you do the calculation, last year was the 100th anniversary of the first valve surgery that was done. And at that time, one of the most dominant valve disease that we had in the world was a disease called a rheumatic disease. So rheumatic disease happens when you have a rheumatic fever, scarlet fever, when you're young, and they develop this sclerosis of the valve, and the valve becomes very, very narrow. So a lot of these patients present with valve stenosis. That's sort of the medical terminology for having a very narrow valve. So the first patient looked like this. This is actually the picture immediately after the operation. She was a 12-year-old who had a rheumatic fever, who was in the hospital for months, and she was suffering from this disease. And the cardiologist, Dr. Levine and Dr. Elliot Cutler, decided that they would do an operation on her. This was the first operation. So this was the operating theater, and there's a little bit of backstory that really doesn't get published too much. So Dr. Cutler at the time thought that cutting out that leaflet that's very tight and calcified, would relieve this disease. So he came up with this device called a valvulotome that's in the right upper corner. It looks like a torturing device. But what it does is it actually clicks and takes that calcium out, and is supposed to relieve whatever narrowing of the valve that the patient has. And you can see sort of the picture on the bottom corner of how he was thinking about doing this. So when he operated on this girl, the valvulotome was not ready. So what he actually did was he got a knife, he punctured it from the apex, and then he cut both corners. So it was a surgery, what we now, even now, to this day, we perform a procedure called a commissuroplasty, meaning that we cut and open that valve so that valve can function again. So he actually performed that, and the patient survived. Patient lived for another 4 years, eventually died of pneumonia, but the patient survived. The subsequent story is that Dr. Cutler developed this valvulotome, operated on 7 more patients. They all unfortunately died because they had acute leakage of the valve, and the heart just did not tolerate. So the heart surgery was abandoned temporarily after this first success in 1923. And fast forward in 1931, this is Dr. John Gibbon, very famous future surgeon, but he was a resident in Boston. And he was taking care of this patient that had a condition called pulmonary embolism, meaning that there's a blood clot that runs and goes into the lungs. Some people call it economy class syndrome. So you can get a blood clot sitting for a long period of time, and the blood clot can go into the lungs. So he was taking care of one of the patients who acutely got sick with pulmonary embolism, got the clot out, and then through surgery, very quick surgery, but he was, as a resident, watching at the bedside how this patient was suffering from breathing. he just could not oxygenate because the blood is supposed to go into the lungs, but because of that clot, the blood does not go into the lungs and can get not oxygenated. So what he thought was, what if you had, so this is the clot that you can actually get. This is actually one of my surgeries that I've done, and these are the clots that can get stuck into the pulmonary artery. So what he thought was, if I can take the blood out of this patient's heart and then oxygenate it and then put it back into the patient's body, then this patient would survive. That's what he thought, and he kept experimenting. So he was a resident in 1931. He successfully done a project in a pig in 1935, 4 years later. But you can see that the first case that was done was in 1953, so it almost took 20 years or more to develop this machine. And what it really did was to fix this condition called atrial septal defect, meaning a hole in the heart. So he took the blood out of the heart. While he emptied it, he was able to repair the hole safely and then successfully close the heart. And this was what the first machine looked like. So this machine got better. We still use it to this day, called a cardiopulmonary bypass. Nowadays, during the ECMO times, the COVID times, there was a lot of patients that couldn't get oxygen, and a lot of patients received this therapy called ECMO. Some of you may have heard during the COVID times. And cardiopulmonary bypass basically is an ECMO. And there is a very interesting article in New Yorker magazine this week saying that ECMO has really changed the death in this period of time because you can keep these patients alive. And these are some of the past histories of cardiac surgery that really made a difference. So flash forward in 1989, he's a cardiologist, Dr. Anderson. He's a Danish cardiologist, and he was attending a meeting, and he thought that, there's all these surgeons that are replacing the valve with a cow valve, just like Mr. Ratliff got. So he's one of my patients who received my valve, but people have been getting these artificial valves, and what he thought was, why can't we crimp this into a metal and then stick it through the groin rather than opening the chest? And he actually got the wires from the surgeons, got some pig valve, and then created in his backyard and did some experiments. After multiple reiterations, so this was back in 1989, in 2002, in France, the first valve, you can see in the right lower corner, was implanted using a catheter valve through the groin. So I'm going to skip this part. So this is what the valve looks like. And nowadays, can you play that video on the left lower, if you can? So the valve is crimped almost to a size of a pen, and you can put it inside of the groin and then implant it that way. I don't know if it plays. How about this one? So this is called a TAVR, transcatheter aortic valve replacement. And can you play that video? I don't know if it plays. So nowadays, we can replace the valve without opening the chest. We can actually go through the groin to replace the valve using this. And contrary to the operations that we have done for a long period of time, we open the chest, we cut the valve out. That's where we're cutting the valve leaflets out. You see the leaflets coming out. And then after this, we put sutures in. We're irrigating to make sure the calcium is not really existent, because that could be a stroke. And then we eventually replace the valve. So you can see sort of the two different invasiveness of the procedure itself. So this transcatheter valve has been studied for a long period of time. So it first got implanted in 2002 in France by Dr. Crivier, who unfortunately passed away last year. And then there were multiple studies that were done, 2011, 2012, and then in 2019, all risk category patients were approved for this new technology. So where can you get this therapy? Barnes was one of the first institutions that had access to transcatheter valves. Now in the United States, there's 823 sites that perform this procedure. And you can see that a lot of them are in California, Florida, and Northeast New York. But even in St. Louis, there's 8 institutions. If you look closely, you can even tell where they are, and all the institutions within Missouri. So there's a lot of places that does this after all the technology dissemination. And in 2022, 98,000 transcatheter valves have been implanted in the United States. So all this is coming. And this is one of the slides that we show. So the blue slide is all the open heart surgery aortic valve replacements that are done. And you can see that in 2018, this new technology has overtook this historical surgery that we have been doing. So what are the shortcomings of these procedures? So one of them is called a bicuspid aortic valve. What does that mean? So bicuspid aortic valve means that usually the aortic valve looks like a Mercedes mark. It's got 3 leaflets. Bicuspid valves, there's only 2. Of note, this picture that is depicted here is written by Leonardo da Vinci. So he has known this through 1500s. So there's a lot of understanding about this, but it happens in about 1% to 2% of population, and it's hereditary, meaning that it can carry down through the family chain. So this bicuspid aortic valve, it looks like this in reality, but when they looked at all these clinical studies, they said that these bicuspid aortic valves are not really indicated for these procedures. So I'm going to skip this slide a little bit. So in these clinical trials, they said that the bicuspid valves should not be in this study, meaning that these are not really well studied. So that's one of the things that I was interested when I was back in Boston. So this is a study that compared the risk of doing TAVRs on 3 leaflets and 2 leaflets, and there was no difference between the 2. However, when you look at a little more in detail, there are some specific anatomy that are good for this TAVR procedure, and there are certain anatomies that are not. So we should not be doing all these TAVRs in these bicuspid aortic valve patients. And we also showed that if you do surgery on these patients, they do very well. So again, these are some of the discussions that we're having in our field, whether these bicuspid patients should undergo surgery or transcatheter valve. One of the other concerning thing is this is sort of the national data. The left one is from California. So what are the percentage of TAVRs being utilized in the United States? So in California in 2021, about 46% of patients were receiving TAVRs, and this was patients under age 65. So American Heart Association comes up with these guidelines, and they recommend that everybody under 65 at this point should get surgery because there's just not a lot of evidence. But in California, 50% of those patients who should be getting surgery now is getting TAVR. And this is another data from the insurance company, and they have also shown that about 45% of patients are getting TAVR. So yes, this technology is very minimally invasive, and it's very good for the patients, but are they being utilized inappropriately for some of the patients that are not really indicated? So what's the problem if you use these TAVRs in younger patients? So part of the problem is that if you put these valves in younger patients, then they tend to fail a little faster. It's sort of a common sense. So if you put a valve in a 50-year-old, that 50-year-old patient would go and play tennis, play golf, run, and that valve will have to open and close multiple times. If you have 80-year-olds that are not that mobile, then those valves probably won't open that much. So therefore, these valves that are implanted in younger patients, they fail faster. This is what it's showing. The younger you are, the faster the valve fails. So what happens if you put a TAVR valve and that valve fails? So what's the data on that? You can put something inside of that. You can put something inside of that old valve, and they do okay. But again, this is a little complicated slide, but what it's showing is that if you put a new valve inside, what happens with the old valve is that it opens up and then it closes the orifice of the artery. So if your heart doesn't get any blood, it's very bad. You're not going to survive. So these are some of the cases that you just cannot really do this procedure, and it happens in about 20% to 40% of patients. So what happens if these patients need surgery? So this is something that we looked at, and this is using the Medicare database. What we showed was that if you do surgery after TAVR valve was implanted, the 30-day death rate is 13%, meaning that it's a very, very high-risk surgery. So to the left is sort of the video. I don't know if this video plays. I hope it does. But if you do surgery afterwards, then the risk of that operation is extremely high, meaning that we sort of have to think when we first pick that valve, which one should we pick, surgery or TAVR? Everyone wants TAVR when they come to my clinic, but some patients just do better with surgery, and that's what you had, Mr. Ratliff. We had a lot of discussions about you, and we thought that surgery was more suitable, and I think that's part of the reason why, hopefully you're here at the moment. So from here on, I'm going to talk a little bit about the future, the main topic. So I showed you some of the things that are upcoming, but I think there's 3 important things in future of heart surgery. So the first thing, despite all these fancy new advancements in medicine, I think the most important thing is the team. We live in a world that we are very dependent. And I personally cannot do an operation without my anesthesia friends. It just doesn't work. And we have to think and we have to understand that we're a team. And I think that concept really has to expand. And in medicine, using this multidisciplinary team has been shown in a lot of fields that it actually provides a lot of benefits. So, the initiation of this heart team concept, heart team means that we see patients with cardiologists and the surgeons. That really has been in the guidelines for a long period of time, since 2010. And we have been practicing it that way, but I think this teamwork is really, really something that's difficult to install. It's not easy. So what is the benefit of heart team? One is that, we see patients together, and patients feel very comfortable. Patients see multiple physicians, and they feel like they're being cared for from multiple perspectives. And then they're getting it from multiple specialties, not just a cardiologist, but also from a surgeon. And they both give the opinions of what to do in those cases. That's how the valve team works. And we actually communicate a lot. Right before this meeting, my cardiology colleague, Dr. Zaharias, called me and spoke to me about a patient. And then right afterwards, another cardiologist called me about a patient care. So we're communicating a lot, and that's sort of the teamwork that we're trying to create within our field. And then it also expedites referrals. So if we think that the patient needs a pacemaker, then we can refer it to our friends fast. If the patient needs surgery, I've already seen the patient. That process becomes very fast. And it really puts the patient care in the center. I think that's the most important thing about the teamwork that we're trying to develop. And I think this Barnes-Jewish Hospital has one of the most premier teamwork that I've ever seen compared to my other institutions that I've been involved in. However, this heart team concept is somewhat in jeopardy. It used to be that, we're all a big family type of thing, but now there's a lot of attacks from the cardiologists and the surgeons against each other. So this is in particular about bypass surgery and stenting. And this was in BBC. One of the major surgeons in UK, United Kingdom, said that a lot of the data supporting stenting rather than surgery is bogus. And he actually said it on BBC. He actually withdrew his name from a lot of his trials, and it was in all these articles. And people are still fighting about who should get surgery, who should get stent. And same thing is happening in the space of the valve. So who should get surgery, who should get TAVR? I think that turf war is starting to happen. We're sort of going backwards. And why is that happening? And why is that happening? I'm going to skip this slide. Why is that happening? It's just because it's very inefficient. When you see patients with 2 teams, it takes longer. And you have to spend more time. You have to communicate with someone. I had to take the call from my cardiology colleague. If I make the decision, I just make the decision. So it's more inefficient in a way. And you really need to respect each other. If I don't really respect the partner that I have, it just doesn't work. And that's very hard to establish, which I will talk about. And there's always a politics within the team. You know, people say that if you have 3 people, there's politics, right? So I think if you have multiple physicians and surgeons and cardiologists, think of how that politics could be. It's very complex. And I think patient care may not be done on, they may be done under patient's individual interest. So this is one of the studies that use some computer work. But one thing that really has been shown multiple times is that if you have diversity, it actually elevates the team. It actually elevates what you can create with a team. Again, I'm not going to go into the details of what this study was, but if you have a diverse group versus a very uniform but very talented group, the group that outshines is the diverse group. If you have a diverse group, you have different opinions, and if you have different thoughts coming in, rather than just elites talking about, you know, the best options. So we have to have that diverse team within our community. And I told you I'm going to show this, but one of the key thing about the team function, this is one of the major books that I've read about teamwork, the 5 dysfunctions of the team. It's actually talking about how to function the team by talking about dysfunctions. And the bottom line is if you have no trust, if you have mistrust, that team won't work. So we just have to create a way to trust each other. And that's something that we've been working on. So you can solve this by some of the structures that you create. So blue is a surgeon, red is a cardiologist. And if you have a structure like this, then you don't really interact with a lot of people. You know, you interact with some cardiologists scarcely, and you just don't have the time to create that trust. So what we have done at Barnes is that we have sort of a core team that we work together so that we can create that bond, trust, so that that will be the foundation of the team. And that was part of the reason why I came, because Barnes had that. There are not a lot of places that have that trust and the teamwork, and we continue to grow because of the teamwork that we have within our space. So the second thing that I think will be important, and I think this is most flashy part of our field, is the innovation aspect of it. We have a lot of innovation coming up in our field, and I'm going to share you some of them. And this is not the most recent innovation. This was a past innovation called a mitral clip. This is a device that goes into the heart and clips the valve and prevents the valve from leaking. And guess who invented this? The person who invented this is probably the most world's famous cardiac surgeon, who is Dr. Oz. So he was actually one of the surgeons that created this device, and he has the IP and still holds that to this day. And again, cardiac surgeons are very innovative, and we try to make sure that we move forward with this. So what else in our field? Again, some of the things that are coming up is AI. So this is a software where you take the CT scans, and then you create sort of the implant of that TAVR valve in a different location. So AI can calculate that for you, and it actually tells you if you implant that valve 4 millimeters from this space, then you can put a second valve in. That will be safe for you, and you will have less complications. All of this are being done through the AI technology. So AI technology is one of the upcoming things in cardiovascular medicine that we cannot ignore. There are some other really, really great things that are happening. There's a lot of AI tools that are happening in EKGs. You get an EKG and you know whether you have a future heart attack or not. Can we do that? There's a stethoscope that you have, and stethoscope that can read and potentially predict your future risk of heart disease. I think a lot of these things are in research at the moment, and I think we will see that in the next decade or two. There's been a lot of advances in heart transplants, and some of you might have heard the news that that heart transplant using a pig heart has been done about a couple of years ago. There's been 2, and unfortunately those patients have not survived, but to me, I think this is more the bigger advance. So we call this DCD, deceased cardiac death transplant. What that means is that in the past, the heart transplant was done only on the patients who had brain death. So unless if their brain is dead, but the heart is alive, those are the rare conditions where you were able to do heart transplant. However, in this day and age, where there's a lot of sick patients with heart disease, we just don't have enough donors. There's not a lot of donors that really need that heart transplant. So what's one way to deal with this? Not to limit the donors to brain death. So what this does is the patient that has terminal disease but has a good heart, what they do is before they pass, they put the breathing tube in, and as soon as they pass, when the heart stops, they put the patient on the heart and lung machine, the machine that I showed you in the beginning. And you revive that heart, you keep it on the machine, and then bring it over and then transplant it. So that's called DCD heart. And this has been proven to be safe if you do it with an excellent expert hands. Barnes has this DCD program, which was started a year ago, and we've been very successful with it. And this has increased the donor pool for the transplant patients that really need that heart. And I think this has been one of the biggest advances in our field, in my opinion, in terms of the transplant. Pig heart transplant's more flashier, but I think this is more impactful in our field. There's other things that are coming. So this is a device called Impella. It is a pump. There's a lot of heart pumps that people get implanted. It used to be a very big device. Now it's a very small device that is really size of a pen. And at the moment, all these pumps are something that goes either through the leg or the arm, and you have to keep that device in until that can come off. The company is now working on implantable Impellas, meaning that they can implant the device in there with some control so that those implantable Impellas will be in their body. They will help pump the heart in patients who are not eligible for transplant for other reasons, and they can go out and live their normal life. So these technologies are advancing. In the field of cardiac surgery, one of the big advances that has been happening slowly, but I think it's going to take off, is the robotic surgery. So robotic surgery originated from cardiovascular surgery. However, at that time, the device was not really precise enough, and it had a lot of complications. After multiple reiterations and successes in other surgeries, there's a lot of OBGYN surgery, there's a lot of urology surgery. Now, the robotic surgery in cardiac surgery has really made a comeback, and it is really gaining a lot of popularity. So when you think about robotic surgery, you think that some robot will come and just treat your heart, and that's not the case. It's more of a puppet, but you can actually sit in the console, which is apart from the actual robot that is doing the operation. So this is what it looks like, and through those console and through the lens, you will manipulate all the tools, and all the arms that are in the patient will do the same movement, but with no tremor and with more precise accuracy. So that allows you to fix some of the disease. In this particular case, this is talking about a mitral valve prolapse. We spoke about that 12-year-old girl that got mitral valve stenosis from a rheumatic disease. Now the leaky valve is more of the common disease in the mitral valve. So what the robot can do is you can cut that leaflet, and then you can put sutures in to repair that portion of that prolapse valve. And again, when you try to do it with a small, tiny incision, this is less than a 2-inch incision, and when you try to do it with a long instrument, you just cannot do the precise accurate movements. But with a robot, you can actually suture it very accurately. So again, this surgery is planned at Barnes in August, so it's coming. So not yet, but it is upcoming. One of the last thing I want to talk about in innovation, it's not really a new innovation, but more of a resurrection. And this is a procedure called the Ross procedure. Dr. Donald Ross, or Sir Mr. Ross, is a surgeon in UK who unfortunately passed away. But what he came up with for aortic valve disease, he took the pulmonic valve, which is on the right side of the heart, and took that valve put it into the aortic valve position, and then implanted a cadaver valve into that pulmonic valve. Why would you do that? It's because of that pulmonic valve. It's a native valve, and it just does not wear out. It lasts for a long period of time. And this was shown recently that if you do a Ross, you almost live the same as the general population, meaning that other surgeries with tissue valve or mechanical valve, you don't live as long, but if you get a Ross, you will live almost as long. So this is a video of a Ross that I did recently. And again, this is what the aortic valve looks like after you take it out. And in this particular case, the valve was very big, so we're putting a ring inside. And then after the ring is implanted, what we do is we implant the valve itself. For the sake of time, this is the ring, and then for the sake of time, I might skip the actual surgery. If somebody's interested, I will show you the full video of the Ross procedure. The reason I wanted to skip this is because I do wanted to tell a little bit of story. Ross procedure really has taken on, and ever since I arrived at Barnes about 1.5 years ago, we started performing this Ross procedure. We did about 25, and all have been great. We're doing in younger patients who is expected to live long, and the results have been good. And this is actually a story that the Barnes Jewish had filmed about a patient's story, so I would like to share this.
Growing up, I couldn't compete in sports, I couldn't run. When I would try to keep up with the other kids, I was passing out. The majority of my life, I had a heart murmur and went to the heart doctor, and I had to have a heart surgery at 9 years old. I found out I had a bicuspid aortic valve. I took care of myself because I knew I had an issue. Eventually, I would have to have surgery on my heart. I went to a dance class with my girlfriend, and when I got home, my ankles had swollen up huge. I called my doctor, and they said go to the emergency room. And I came in, and they found out I was in severe heart failure. I had to have surgery. I had already researched my options at that point. The Ross procedure, no one in my town does that, and so I had to get a referral. I got an appointment set up to see Dr. Kaneko, and he was very open with me about the procedure, about the risk. I knew I was in the right place.
The Ross procedure, you harvest that right side pulmonic valve and then implant it in the aortic valve. And for the pulmonic valve, you substitute it with what we call a homograph. For younger patients who has very long life expectancy like Chris, it's a great option for those individuals. I was very honest with Chris that he can have this surgery safely at Barnes Jewish Hospital, and he was comfortable with moving ahead with the procedure.
I almost waited too long because I don't think I would have survived a few more months if I would not have gone to the emergency room. I actually think it saved my life.
With this particular procedure, he should be able to get back to his normal life. Not only that, he should be able to do much more than what he was able to do before.
Life after surgery has been great. I think it was one of the hardest things I've ever gone through in my life, but it was worth it. I've always wanted grandchildren, and I didn't know if I'd ever live that long, but now I know, maybe hopefully see my grandchildren get married. So as the months go by, it just gets better. You know, I'm 57, and it's like I'm young again.
Well, this was a great video. There was multiple retakes. I'm not going to tell you how many, but I think Ross is not for everyone. There's a Ross registry. They put my name in the registry. So I think that's some of the excellence that we have and we provide at BJH. The last but not the least is education. We got to foster the future generation. And this is Dr. Michael Davidson. He was a cardiac surgeon. He was a cardiac surgeon at Brigham Women's Hospital. And he was my mentor during my training. And he was tragically shot when I was a first-year faculty. And he passed away after that. And I really sort of took on his legacy, and I owe all my success to him. He was a visionary. He was a visionary that really thought that meshing with cardiology and cardiac surgery was important. So after I finished my surgical training, I actually spent 1 year in the cardiac cath lab. That's where the interventional cardiologists train. So I cross-trained, cross-pollinated with them. So I sort of live and sort of think similarly with the cardiologist, and I think that has been part of my success. So Thoracic Surgery Foundation is one of the foundations within our Society of Thoracic Surgeons, and there's a Michael Davidson Fellowship, and Dr. Alaktar, who is our fellow at the moment, received this award, and he's been training with us over the past year and learning how to do both catheter procedure and the open procedure, and we're trying to carry on that legacy. We have to foster that new generation. So I think all of that will be critical. But at the end of the day, I think most importantly, the team, going back to the teamwork that I originally spoke about, this is the study that was published in Harvard Business Review. What it basically says is that if you are happy, you live longer, and you're gonna have a better life. So why not make it happier with the teamwork? So my vision of the future in cardiac surgery is teamwork, innovation, and then education. I think those three will be the pillars of our success in our field. And I am very sure that BJH will be center of that innovation and future of cardiac surgery. Thank you very much.
Any questions for Dr. Kaneko?
Penny?
I was wondering for the TAVR procedure, why you go through the groin? Why wouldn't you go through the arm?
Yes, very good question. I don't have a pen, but currently the valve size is about the size of a pen. So unfortunately, the arm, either the wrist or in the arm, the vessels are not big enough at the moment. They are working on a very tiny valve. Tiny, but it will expand and be a heart valve. So maybe in the future, we will be implanting these from the wrist or through the arm. That may be another future that's coming. Again, I can't explain all the innovations that are happening. It'll take hours, but yes, that's part of the innovation that's occurring in our field.
Christine?
I'm not a nurse myself, but I'm asking for a lot of friends who are nurses. As you talk about teamwork, can you reflect a little bit on how you involve all the other people who are involved in any of these procedures
Yes.
As part of the teamwork?
Yeah. A lot of the care that we provide is both outpatient-based, inpatient-based, and then in the operating room. And all of it, I'll start with the outpatient. We have this valve clinic that we organize to see patients with a valve disease. I see patients with a cardiologist. I see patients sometimes with an imaging cardiologist. But the person that's in charge is our nurse coordinator. So nurse coordinator coordinates everything, when to see me, my partner, when to get all these imaging. Without that coordinator, our team will not function. We always call them the boss. So, that's sort of the concept that we have. And it goes very well when you do it that way. And in the operating room, of course, we can't do it without the help of the OR nurses. So if you have an excellent OR nurse, all you have to do when you're doing the operation is you just have to put your hand out. And then they will hand you what you need. And you don't really have to think. That teamwork that you create goes beyond just the capacity of a surgeon. So by having that team, I can expedite the surgery faster and more efficient. Therefore, the time will be shorter. I can go on and on about these examples, but the teamwork that I'm talking about is not just with the physicians, it's with the nurses, it's also with the perfusionists, it's also with the administrators and patients. So all of that is included.
Any other questions? Penny has another one.
I have to bring up the ethics question.
Yes.
Especially with the terminal patient as opposed to the brain dead patient.
Yes.
Do you have an ethics team
Yes.
working with you as well?
Wonderful question. So one of our surgeon, who's a WashU cardiac surgeon, he has masters in ethics. And we encounter all these ethical dilemmas all the time. So I spoke about the New Yorker magazine article. So what it says is that by putting patients on ECMO, you can basically keep those patients alive for a long period of time. But what do you do if there is no other pathway from there? Do you stop that ECMO? Because patients on ECMO, they speak, they can talk, they can eat, they watch TV, they play games, right? But if you stop that ECMO, they will die immediately. So what do you do with these patients when they have no alternatives? So there's a lot of ethical dilemma that we have and we live in, and I think those will probably be highlighted in the next decade or two. And all of that is changing rapidly too. Like, what do we do with AI if AI is starting to diagnose patients? What if you said that my AI surgeon in the robot will do the operation? Would you feel comfortable with that? I think that's some of the future that's upcoming. Maybe we're overthinking this, but we do encounter ethical dilemma all the time, and it's constantly changing with the advances. And I'm sure we're not going to run out of ethical dilemmas in the future. Yes.
Yes, good afternoon, everyone. My name is Harry Ratliff. I'm on the board of the foundation, but I wanted to come here to personally thank the entire team. When Dr. Kaneko came here about 18 months ago, I was one of the first patients. I had a arterial valve replacement, and that teamwork that they talk about, everyone from the physicians, the nurses, even down to the staff on the floor, the rehab individuals saved my life. And it's just that true. The cardiologist told me that if I waited 6 months, I'd go into congestive heart failure. I said, nope, we're going to get this done. So as they talk about teamwork, I know how important that is, and I just want to publicly thank the doctor and the entire staff. And now I'm on the board of the foundation, so I hope I can be an advocate for the work that the foundation does in order to help everyone. I wasn't on the foundation when I had the surgery. I was just another patient, and I was very well taken care of. A lot by Barnes. I was born at Barnes a long time ago, so I have an affinity to the hospital and the work that we do. So I just want to publicly say thank you to the entire team that's responsible for me being alive today. So
Thank you.
Any last questions? And if not, thank you, Dr.
Thank
Kaneko.
you.
That was a wonderful presentation. I'd like to welcome Joan Chaney now for closing remarks. And in addition, you will see some beautiful flower arrangements on the center of your table, and we hope you feel welcome to take those home.
Thank you, Dr. Kaneko, for that most informative presentation. And a very special thank you to our Legacy Circle friends. Thank you for your time and your attention this afternoon, and we hope to see you very soon. Have a great afternoon. Thank you.